I'd like to welcome everyone to today's webinar. We are so excited this afternoon to unveil CADTH's new report and expert guidance on solutions to the pan-Canadian issue of emergency department overcrowding, an issue that has garnered much interest and attention over the last few years. And in fact, it only takes a glance at the news headlines to see that emergency departments across Canada are under intense strain. They're overwhelmed, they're overcrowded, and although emergency department overcrowding is not a new phenomenon, data shows that the issue is worsening nationwide. Recognizing the critical importance of addressing this pan-Canadian and systems-wide issue, CADTH's report aims to support decision makers find and implement solutions that work. My name is Sudha Cuddy. I'm the Executive Vice President of Evidence Products and Services at CADTH, and I have the pleasure of being today's moderator. Before getting started, I'd like to acknowledge that I'm speaking to you from CADTH's Ottawa office, which is on the unceded territory of the Anishinaabe Algonquin Nation. I recognize, honor, and respect these lands upon which I live, work, and play, and I'm personally committed to do my part towards meaningful reconciliation and to work to implement the spirit and intent of the calls for action from the Truth and Reconciliation Commission. This slide has our standard disclosures and highlighting that we're funded by the federal, provincial, and territorial ministries of health, except for Quebec, and that we receive application fees from the pharmaceutical industry for reimbursement reviews. So today, I'm thrilled to be joined by an amazing and diverse panel of experts who will share their unique experiences and understandings of emergency department overcrowding in Canada. And whether you've joined us today as a patient, a caregiver, an advocate, a clinician, an administrator, a researcher, a health system leader, and/or a decision maker, I'm certain you'll be able to relate to some of the insights and perspectives shared by our panelists today. And it's our hope that you will walk away with some new ways of thinking and approaching this important pan-Canadian issue. So this is the agenda for today's event. We'll begin by having our external panelists introduce themselves a little bit more personally and provide some opening remarks related to their unique experiences with emergency department overcrowding, after which CADTH's project lead will provide a high-level overview of CADTH's work on ED overcrowding with a primary focus on the guidance. We will then head into a discussion about CADTH's guidance in light of the emergency department crisis, and really highlighting key considerations for health system leaders and decision makers and how we might be able to take meaningful steps towards alleviating this very real issue of ED overcrowding in jurisdictions across Canada. We'll likely have time to take several questions from the audience as well, so please feel free to submit questions at any time by using the question and answer tab in the Zoom control bar. And finally, today's webinar will be recorded and posted on a special section of CADTH's website, which will bring all of our ED overcrowding work together under one digital roof. We'll be putting the link to that website in the chat in this webinar. We'll also be sending an email out to all registrants after the event with a link to our collection of work, including the final guidance. So this next slide is our panelist disclosures. And I think with that, I am now going to pass the virtual mic over to Dr. Tasleem Nimji. Dr. Nimji is an ER physician at Humber River Health in Ontario, where I had the immense pleasure of working side by side with her during COVID. She is a digital health leader and a consultant and a former Chief Medical Innovation Officer at Humber River Health. You can find Dr. Nimji's full bio as well as the other panelists' bio on our ED Overcrowded webpage, which again, we will have linked to in the chat. Over to you, Dr. Nimji.
Thank you, Sudha. I'm really excited to be here today with this amazing group of leaders. And I won't, Sudha explain sort of my context to which I'm coming to this conversation. I think, if I reflect on this topic, I look back at what it felt like to practice emergency medicine, and it has absolutely been one of the greatest privileges of my career to date to be involved in emergency medicine care. And when I think about what it looked like when I first started this work to what it looks like now, it's really changed over time. And, that change is reflected in a few different ways. So when we think about, number one, the amount of information that we have as care providers, especially as our systems become increasingly digital, so that amount of information has increased, which is wonderful in so many ways, but it does mean that we have more information that we need to get through to be able to provide the best care for our patients. And then in addition to that, our our emergency departments, in terms of volume and complexity of patients, has changed. There are far more patients that are presenting sicker. And by the time you come to see a patient, you are sort of having this amount of sort of cognitive load, and the goalpost keeps moving, and you're trying to do the best work that you can. And the patient already, in some ways, feels a little failed by the system. They've been waiting longer than they wanted to or should have had to for the care that they desire. And so this topic is just so timely and so important as we all sort of aim to do the best by our patients. And I'm really excited to be with everybody today to talk about it.
Thank you so much. Our next panelist is Maggie Carastacci, who is a patient, a caregiver, as well as executive director at the Canadian Association of Health Services and Policy Research in Ontario. Maggie is a really well-respected leader in the area of patient engagement and patient experience. We're so lucky to have had her as part of this work. Over to you, Maggie.
Thank you so much, Sudha. My name is Maggie Carastacci, and I'm a caregiver to my 90-year-old mother who lives with me and to a sibling who depends on me for complex medical care and system navigation. I'm also an immunocompromised patient with a chronic condition. I'm here today as a caregiver and patient who's had to use the emergency department more frequently than I would like, especially over the last few years, and also as someone whose entire working life has been in healthcare. I've worked in clinical settings, in analytics, and in health policy, but in fact, I have learned far, far more about the delivery of healthcare in the time I've been a caregiver than I have from any textbook, any conference, any work experience, or any professional accomplishment. The lens through which I view the health system now is different because of my experience as a patient and a caregiver. I want to be really clear that I'm an N of one, and I do not speak for other caregivers or patients. I do, however, think that we share many of the same insights, concerns, and thoughts about the issues and possible solutions. Thinking a little bit about what I wanted to share with you today, I settled on the story of my mom from last winter, of course, with permission to share. To set the stage, you have to know my mother. She is a feisty, previously fit, 90-year-old Irish woman who gives no acknowledgement to any restrictions of her age. She grew up in Ireland during the war, and she knows poverty and hardship. If I may, for a few minutes, let me take you back to an icy day last winter. On this particular Monday morning, I was going about my day, rushing to an appointment. I yelled goodbye down the stairs to Mom as I left, telling her not to go out, as it was miserable outside. Little did I know it was already too late for that. I pulled out of my garage only to see in my rearview mirror my mother with a snow shovel in her hands, lying at an awkward angle at the edge of the driveway, head in the snow, and her skin as white as that snow. As I rush over to her, I see that she can't move her leg and that she's in extreme pain and likely hypothermic at this point. I called 911 immediately. We live in rural Ontario, and just getting to a hospital can be a challenge, especially in winter. So that was my first worry. On this occasion, however, the paramedics came quickly and were outstanding. They wasted no time getting her to hospital. And here's where the roller coaster begins. So stay with me for a minute, if you will. Once at the hospital, I'm sent to the emergency waiting room, and Mom has to stay in the ambulance because there's no room in the ER, and they can't offload her. I naively imagined that meant a minute of waits, a wait of minutes, not hours. I'm not able to see her, and I begin to worry that her tough Irish persona will mean she will insist she's okay and that it's only a wee bump. I sit and wait in the absence of any information about her, counting the hours going by. At hour 4, I find out she's still in the ambulance bay, and I'm allowed to go back and see her for a few minutes. This part is really hard for me because this is where I realized that tough lady I've known all my life is nowhere to be seen. She's disheveled, she's weeping, and she's unable to lie still because of the pain. And she's cold, although they try to keep her warm. I'm sent back to the waiting area with both of us in tears at this point. More hours pass, and I still haven't been updated on what's going on. She's eventually brought into the emergency department. And I only know this because I'm the pain in the neck person who is regularly asking the rotating people at the desk what my mom's status is. At this point, I take heart because I think that this means that she will now have some relief, but I was wrong. As the hours tick by and I haven't heard anything, I begin to panic, worrying that there's some underlying problem that we didn't know about, or that at her advanced age, she's had a heart attack or a stroke, or even that she's died. Eventually, I decided, I know I did the wrong thing, but I decided to follow another family that's being brought into the emergency area. And after some poking around, I find Mom. No one had talked to her and she didn't know what was going on. She'd not seen a doctor, had not been x-rayed, and had not had anything for pain. She wasn't sure if a nurse had seen her yet. Throughout this time, as you can imagine, I was getting numerous calls and texts from worried family members. I had no answers for them. And I can't tell you how many times I texted the response, still waiting. I will let you know when I know something. At this point, I was allowed to stay with her in the hallway. My mom is of the generation that no matter how bad things are, she will not make a fuss. She will not call a nurse. She will not tell anyone she's had to use a bedpan, especially as she lies in the hallway. And she certainly won't ask for pain meds. Her fall happened early in the morning, and by the evening, I finally was able to find a physician to talk to me because I persisted in telling anyone who would listen that I needed to speak to someone familiar with her case. She still had not had an x-ray at this point. Now is probably a good time just to remind everyone how important it is to recognize and name the power imbalances that exist in medicine. As a caregiver, I lack power, and I worry about rocking the boat, worry about negatively impacting or delaying her care. I had to seek out ways to be involved in her care because I wasn't invited to participate, to be part of the care team. I worry about the impact of my voice on the delivery of care. And I struggle with finding the balance between being assertive, but in the right way, having my voice heard while not raising it too loudly, advocating for her, but doing it with a deferential smile, demanding change and rocking the boat if needed, but making sure everyone stays in the boat, being powerful while feeling powerless. Mom was eventually imaged and diagnosed with a broken femur and a broken hip. She was admitted to the hospital a couple of days later after spending those days on a stretcher alone in various hallways. And she had surgery 4 days post-fall. During those days, she was existing in an information vacuum, so it seemed to her there was no end in sight. She knew of no plan. I'll note here that I had to leave her there on day 2 because of a COVID outbreak in the hospital. I think I speak for many patients and caregivers when I say that it's vitally important to include a patient or family determination of what an acceptable outcome should be as we seek to alleviate the problem of ER overcrowding. For me, it's less about the total time waiting or the fact that others had to go in front of us. Most patients and caregivers understand the importance and fairness of triage. And I think most understand the tremendous strains that the health system, specifically emergency care, is under. We expect long wait times right now, and it's part of our calculus in determining if and when we should go to an emergency. What is tough is sitting in a worried and anxious state for long hours with no information and no communication. It's an anxiety-invoking experience that sets one's imagination on fire. As opposed to simply thinking about the time waiting, and this applies to myself as a patient as well as in my role as caregiver, I would rather have us think about whether I knew and understood the status of care while we were in emergency, whether we left with a diagnosis, a plan, a clear understanding of what's going on, and distinct follow-up, and whether there was an attempt to have symptoms managed even before a final diagnosis. And finally, and importantly, whether I was part of the decision-making. I think too often in the name of expedience, especially during times of chaos, shared decision-making gets set aside. As time goes on, I often think about my mom's experience, Her surgery, when she had it, went really well. She recovered and went to rehab, where she surprised everyone with her grit and determination. The work that CADTH is doing that we're here to talk about today is a great step towards finding solutions to the problems of ER overcrowding. We can do better. When I reflect on our experience, I draw a distinction between treatment and care. And I'd say in the end, my mother received excellent treatment, for which we are truly grateful. But she did not, in fact, receive excellent care. And I think we can improve on that. And I think we can and we must do better. Thank you so much. And I'm sorry to have taken so much time, Sudha.
No, Maggie, thank you so much. Thank you for sharing your story. And I can only appreciate how hard it is to relive that and share that with, an audience of 500 plus people. So really appreciate you taking the time. And you always have a way of grounding us, I find, in your comments and your eloquence and reminding us what is really important in all of this work. So thank you. Our next panelist is Dawn Petta. Dawn is a nurse and clinical educator with Alberta Health Services, but she is also the president of the National Emergency Nurses Association, otherwise known as ANENA. Thank you so much for joining us, Dawn. Over to you.
Thank you for having me. So let me paint you a picture of the start of our day today. This is what is in the waiting room. 43 adults, 21 pediatrics waiting to be seen, 7 admissions, a patient on a heparin infusion, 6 patients with EMS who are about to time out, and 7 pending EMS to arrive. In the back, we have doubled up 2 patients that were in the same trauma to make a crash bed, and just as we did that, we had a code called from the main entrance of the hallway. The solution is not to add 3 more beds down the hall. All I have is half a tank of oxygen and my 2 hands. No one can hear me if I need help. The waiting room is calm now, but we have patients who have been here more than 14 hours. This is a summary from one of the emergency nurses in Canada describing their department. The scenario here is a common one, and the impacts are far-reaching. Rural is impacted because people don't want to wait. They would rather drive 20 to 45 minutes to a smaller community in hopes of being seen sooner. Patients don't recognize that we have limited resources in rural and less staff to provide care. If the patient is sick and needs to be transported now to a regional or higher level of care, and can't be due to overcapacity, then rural emotionally and physically foots the bill. For those who live in rural communities, an increasing number of hospitals and their EDs are closing, thus causing a significant reduction in access to emergency care in these areas. Some other nurses' responses. Many of our rural EDs across the country are closing or experiencing reduced hours. This is due to many factors, including a shortage of RNs, physicians, lab and X-ray staff. The Rural and Remote Recruitment Incentive has assisted in recruiting new grads to rural EDs, but the new grads are being put in positions where they are working as the only RN and are being pushed to take advanced level courses. Some of the EDs are virtual care sites where they have no physician that can attend, but instead obtain orders from a virtual physician. The premise behind the virtual care model is to relieve pressure from the overcrowded larger EDs and retain the ability for patients to access care close to home. But is this safe? Nova Scotia has been working on solutions that seem to be effectively reducing some of the key issues by providing multiple avenues of primary health care, by initiating a test-try model with a scale spread plan, by utilizing mobile primary care units, virtual care, as well as pharmacy walk-in clinics. Alberta has also been utilizing some of these models. The 4 top issues facing us globally: nursing recruitment. Staffing must be viewed holistically, which is why new nurses coming into the ED is imperative. But how do we achieve this? ENA and its partner organizations have requested $324 million for nursing workforce development programs, which are key in growing the pipeline of nurses. But what are we doing to grow our pipeline? We are using a Band-Aid approach with agency nurses, but what about compensating those who have stayed? Retention. How do we keep nurses? And the answer may be, how do we invest in our nurses? Attracting nurses to the ED is one thing, keeping them is another, especially with the rate of nurses leaving the ED within the first few years. We need to be creative and come up with strategies like other organizations have created. Alberta Health Services Clinical Transition Education has created an ED orientation program to increase consistent education and support to our rural ED staff and sites provincially. This work has been foundational for me as a rural educator. The CADTH stated the key to reducing harm to patients is keeping staff nurses at work. Safe work environments. Nurses want to feel safe and be in a culture that promotes this practice. Violence campaigns and no bullying have been around for years, but the problems are reoccurring and staff are still being injured or killed. The emotional stress and moral distress caused by working in chaos reaches beyond the workplace. Staffing levels. Standardizing staffing levels should be driven by evidence-based approaches to ensure optimal patient care standards. California has had mandated RN to patient ratios since 2011. Data has shown there were lower rates of hospital-acquired infections and lower rates of patient readmission after discharge. Data doesn't lie. Overcrowding is impact and contributes to recruitment, retention, staff safety, patient safety, and staffing levels. If you ask any nurse what would make them want to come to work, it is never about the money. It is about feeling safe, having enough staff to care for our patients, and feeling heard. Somewhere along the way, in many decisions, we have forgotten safe patient care. And I thank CADTH for the work that they are doing. I will leave you with this final quote I got from another ED nurse. In a busy, overcrowded emergency department, I don't have time to brush teeth, reposition as often as we should, toilet people, ensure they are fed, and regular medications given on time. And every day I work, I go home with the guilt of not doing the basics of care because I am just trying to put out the fire.
Thank you so much, Dawn. And thank you to all of our three panelists so far for speaking with your insightful remarks, as well as really your passion. I think we really wanted you to speak to a day in the life, and I think you've captured that also well. Now I'm going to turn the mic over to CADTH's Gino DeAngelis, our Manager of Clinical Research within Evidence Products and Services, who was the project lead for all of this work on emergency department overcrowding. Gino, over to you.
Thanks, Sudha, and I want to echo your thanks to our speakers for sharing their opening remarks and acknowledging that their experiences with ED overcrowding are really reflective of why CADTH undertook this work. So acknowledging the pan-Canadian relevance of the issues of ED overcrowding, CADTH convened its Health Technology Expert Review Panel, or HTERP for short, to develop objective, impartial, trusted pan-Canadian guidance to inform decisions about which evidence-informed solutions should be considered to help alleviate ED overcrowding in Canada. So for those of you not familiar with HTERP, they are CADTH's expert committee that develops recommendations for non-drug health technologies. Beginning with the development process, we engaged a wide range of people with extensive personal and/or professional experience with ED care throughout our work. And that includes patients, family members, community members, emergency department clinicians, and staff as expert consultants, peer reviewers, and HTERP members. Some of them are in the audience today, and I'd like to express our gratitude for contributing their time, their expertise, and experiences. So CADTH conducted evidence and information reviews that HTERP used to inform their deliberations and to develop their guidance. We produced 5 reports that covered factors contributing to ED overcrowding and interventions that have been studied for their impact on alleviating ED overcrowding. We looked at new and emerging interventions. We conducted a report that assesses the impacts of ED overcrowding on quality of care, patient safety, and staff well-being. We looked at demographic, resource, and utilization patterns of EDs in Canada. And lastly, we provided a summary of our multi-stakeholder dialogue sessions. To set the context for their guidance, HTERP acknowledged some key facets of the situation in Canada, including that ED overcrowding is a complex health system issue and not a problem where sole accountability for causes, impacts, and solutions lie within the ED and its operations. They acknowledged that EDs operate within hospitals and broader health and social systems, which contribute to the experiences of and potential solutions to overcrowding. This figure here presents a conceptual model of patient flow through the ED as it's situated within the broader healthcare system. Output factors, such as the misalignment between acute care bed capacity within the hospital and population needs, and input factors, so factors related to the misalignment between care available in the community and population needs, including care outside of regular business hours, respectively, are the main contributors to ED overcrowding in Canada. They acknowledge that health system capacity has not kept pace with the growing and changing healthcare needs of the population, which results in overcrowded EDs. And also, we're likely to observe a higher impact by implementing strategies that focus on patient flow out of the ED and hospital and factors that relate to demand for services in the ED relative to throughput factors or factors within the ED specifically. In terms of the specific guidance, HTERP recommends that interventions to alleviate overcrowding need to align with the main contributing factors to ED overcrowding in the particular context in which they will be implemented. With this, the first step to identify evidence-informed solutions is understanding what the potential bottlenecks are to patient flow in a given context where ED overcrowding is being experienced. HTERP also asserts that transparency and accountability should be key principles in operations and recommends identifying and ensuring clear roles, responsibilities, and reporting relationships embedded with an accountability framework across health system partners. HTERP recommends that each province and territory should mandate consistent and comprehensive reporting to all hospitals to the Canadian Institute of Health Information's National Ambulatory Care Reporting System, also known as NACRS. HTERP's guidance includes an evidence navigation guide to support the identification of evidence-informed interventions, which includes a list of interventions that have been favorable published evidence or otherwise have been identified by HTERP as showing promise based on expert opinion and experience. And with that, we invite you to visit our CADTH ED overcrowding page, where you can find more information on the published reports that I mentioned, including HTERP's guidance document with key messages and an interactive dashboard containing ED utilization and demographic data.
Thank you so much, Gino. I appreciate the presentation. And really, I know a tremendous amount of work went into the project, so a big kudos to you and the team. I'm now really delighted to move on to engaging with all of you who've joined today's webinar and to the Q&A portion. So you can submit your questions by using the Q&A tab in Zoom in the control bar. And so while people are starting to think about their questions and think about what they may want to ask, I'm going to sort of kick us off with a question for Dr. Nimji. Dr. Nimji, technology has changed how we practice, but we know it's not the panacea for all ED-related issues. It may be helpful, but there may be instances where it's not. And when used appropriately, it can help improve interconnectivity and communication. And some hospitals are further along than others with the use of technology. Can you speak a little bit more about how do we leverage and scale innovative technologies in a way that leads to better and more accessible care within the emergency department?
I'm happy to see that. I mean, like with any problem that we're trying to solve, we really have to hone in on what exactly is the problem that we're trying to solve and what are the opportunities there, as opposed to looking for how do we apply technology for applying technology's sake. But I do think that when we look at the major supply-demand imbalance that we have and the problem of ED overcrowding, technology and its application it's a foregone conclusion that it is going to play a major role when it comes to disruptive solutions that really help in this area. Technology allows us to scale while keeping costs manageable over time. And it is the one thing that allows us to do that. And again, when we talk about supply and demand, especially when it comes to human resources, which both Maggie and Dawn talked about in their opening remarks, we are going to have to lean on technological solutions to help address that piece. I think we did some things in the emergency setting during the pandemic, like start exploring what does virtual urgent care look like as an example. I think those solutions were applied very quickly, not always with the right infrastructure in place to support patients and providers to deliver that care. So there's still a lot of learning that has to happen there. But I also think when we look at the amount of data that we have available to us as hospitals and hospital systems become increasingly digital, we will have to depend on the intelligent use of technology to actually synthesize that data for us to help us with decision making so that we can become more efficient. So this goes back to sort of the input, throughput, output, which kind of so beautifully sort of defined in terms of that journey. In each one of those stages, there are potential applications of technology, and we're seeing it happen at many hospitals in its early stages. Your comment about it not being a panacea is a key comment. There is still bias that we have to work through, and what does that look like in some of these solutions? We have to look at access, digital sensitivity, and equity is a big piece of that conversation. But I am sort of a technology hopeful. I do think that it is going to help us through some of this challenge that we're facing.
Great. Thank you so much, Tesleen. Maggie, I'm going to turn the next question to you. In your opening comments, you really spoke a lot about communication and partnering with patients. Can you maybe speak a little bit around how can organizations, whether they're hospitals or health regions, partner with patients in meaningful ways to advance these efforts and improve the patient journey?
It's a great question, Sudha. I'm going to address it in two parts. So I'm going to start with that system question of larger regions and health authorities and organizations. One of the things that happened during COVID that really surprised me was that it seemed that in a millisecond, we went from having caregivers and patient voices at the table, being part of policy making, et cetera, to them being shut out completely and viewed as visitors alone. So one of the things that I feel quite strongly about is the importance of co-design and having patients and caregivers embedded in policy-making tables like CADTH that you're doing now, making sure that they're embedded in a meaningful way, not just an ad hoc way. And then really at a concrete, more local level, one of the things that I found really difficult was just the waiting in this vacuum where I had no information whatsoever. And when I would go to the desk, there would be a different person there each and every time who didn't know my story and didn't know my mom and had to look it all up. So even something as simple as being assigned a volunteer or something of that nature that is assigned to however many families in the ER that they have capacity to look after. If I had just been told at frequent intervals, your mom is in the ER, we have not had an x-ray yet, we're waiting for x-ray or whatever it might be, it would have alleviated an awful lot of what I imagined. So it does not need to be sophisticated, and it does not need to be really time consuming. But I think that there's a role for even training volunteers to partner with patients in the waiting room or patients in the ER waiting.
Thank you so much. Dawn, I'm going to ask you the next question, and it's around emergency department overcrowding potentially being due to chronic diseases that could be potentially avoided with better treatment options. Can you speak a little bit as to what you're seeing within Alberta Health Services and the emerge around patients coming in that have chronic diseases that could be treated elsewhere?
Yeah, absolutely. I think you answered the question. People do have a lot of chronic diseases and they could be treated elsewhere. The problem is we have lack of primary care physicians across the country. We have lack of access, like for the city I live in. We only have the emerge department. There's no there's an evening clinic that just opened 3 days a week, but there's no urgent care. There's nowhere else to go. And I know this is a common problem across the country. And so I think until we can fix that or grow, utilizing nurse practitioners, physician assistants, to get people that access to care, I think the problem's going to be ongoing.
Thank you. Gina, I'm going to ask you the next question. One of the things we learned through all of this work is that many of the factors around overcrowding are actually outside of the control of the emergency department. Can you speak a little bit to the guidance and perhaps the toolkit in terms of what tools and supports are available for organizations and hospitals to find solutions to emergency department overcrowding?
Yeah, thanks, Sudha. So I do invite everyone to have a look at the guidance document if they haven't had a chance to yet, but essentially we have put together a navigation tool. We know that context is going to be very different for each jurisdiction, each hospital. So there's some guiding questions in there that we invite our users to have a look at that will really help navigate, deciding on what the context is, and also considering what are some of those implementation considerations that need to be thought of when we're looking through these very important considerations.
Thank you so much. Just scrolling through the questions here. I'm going to ask you this question. In your assessment of ED overcrowding, are you concluding that external factors, for example, timely and appropriate access to primary care, and internal factors such as improving flow throughout the emergency department are the equivalent or of the same impact?
Yeah, that's a great question. There's certainly both very important influencers. I work at a hospital. I work at Humber River Health, and this is a hospital that has comparatively good flow. And I would argue that that is because of the deployment of a lot of technology, including a command center that helps us sort of move things through the entire continuum in the hospital, not just the emergency department. So that helps us with throughput in the ED, but I also recognize that not every hospital has that kind of technology. I think it's important to comment on the amount of sort of primary care that is now being handled in the emergency department. There is absolutely a shift or a change in terms of what is the kind of care that we provide in an ED, and that the breadth has really increased over time, even in my career in the ED. And so that is important because we have to look at solutions with a very different framework now, knowing that the population itself has changed. And so we used to think about ED diversion. We used to talk about, can we identify who the sort of low acuity patients are that could be handled in the community by primary care providers, example, and come up with techniques to sort of divert them from the ED. But as both Don and Maggie have talked about, and Gino as well, that access in the community to those resources is also a challenge. So diverting them, the question becomes divert to where and to who? And I want to be fair to my primary care colleagues as well, that they are also facing challenges. And so this again goes to, can we do a better job? Even if you think about throughput in the emergency department, we all have peaks and valleys in terms of our overcrowding. There are times of day when many of our departments tend to be able to handle incoming volume better than other times of day, and that reflects what's available in the community as well. But there are, solutions that are now being deployed to look at, can we streamline some of that flow? Can we communicate with our patients remotely that want to come to an emergency department, get some information on them, and say, you know what, your particular need from the ED can be handled by the ED, but you don't need to come in right now. We can actually give you a time to come in queue so that your experience of waiting is more patient-centric, and that you're not sitting in an overcrowded ED, and that when you do come in, we will actually have more resource to meet your needs. So there are tools like that we can actually look at to better match the supply and demand, even within an emergency department.
Thanks for that, Taslim. There's a question here, which I'm actually just going to put out as a comment because I think it's very, it ties along to what you were just saying. I'm a nurse at a hospital where we are having a very difficult time finding flow throughout the hospital to aid in the crowding of patients in the ED. We're finding most of our shifts are caring for patients who have been admitted for over 100 hours, waiting for a bed within the hospital, therefore creating no room to care and treat the true ED patients. So I think it's just, more of what you were saying. And I think also a very similar finding within our report around this concept of input, throughput, and output. Maggie, I'm going to turn the next question to you. When we talk about starting to engage with patients in meaningful ways, do you have any suggestions on how we can measure the patient experience?
So, I think that using the opportunity of having patients there and experiencing their time in the ER right then and there, it's really important to, I don't want to say survey, but have conversations with them about what they're experiencing and, what can be done differently. I think we talk about the patient experience in the ER, and we have to remember that when patients are in the ER, particularly after waiting a long time, often in pain, they're emotional, things are difficult. We don't often take that into account as well as just the physical care that we need to be giving them. So I think it's really important that we find ways to measure that, taking into account the situation that they're in. Sudha, if I can also just add, I'm going to skip to your previous question because I just wanted to add something about that, about primary care. In my case as a patient, like Don, I live in a rural community. I was ill, particularly post-COVID, and I had a particular sort of crisis moment, if you will, called my family doctor. I was not able to access him because he was working in the ER in another town, a few towns over. So I couldn't have access to him for about a week, which meant that they sent me to the ER. I was seen in the ER, another ER, sent back to primary care, who sent me back to the ER and then back again to primary care without any treatment plan, without any real resolution. And it was nobody's fault, so to speak, right? My doctor was trying to get me the best, quickest care possible. And they were trying to deal with a patient they didn't really know. So, I think the issue of primary care is an important one that we have to keep in mind.
Okay, thank you. I have a question, Dawn, for you around mentorship. So we spoke a little bit about workload and about retention. Can you speak a little bit about the role of mentorship in retaining nursing staff within the eMERGE setting?
Yeah, and I think mentorship goes even for retaining physicians and nursing. And I do think it's important. I think you have to address kind of the stresses too, because I think there's a lot of burnout, which isn't an excuse, but it's hard to, mentor others when you're not believing in what you're mentoring anymore. So I think it's kind of like a double edge, right? So I do think it's important. I think making sure that they're partnered with somebody that they can go to, if they have questions, not to feel bad if they have questions, because a lot of people think, well, you're a nurse, you should know. And myself, with almost 30 years experience and also as an educator, I still don't know everything. I still have to ask questions or seek out answers. And so I think it's just being transparent with your own practice and making sure that you're always open to be that mentor for somebody.
Thank you so much. Tesliam, I'm going to give you this next question around the benefits of public reporting of live ED wait time estimates, both online and on screens in the ED. And I'm cheating a little bit because I do know about an initiative at your hospital around this topic. So hoping you can address this.
Sure. So historically, what we have seen is some hospitals will use, they'll use historic data, as well as what's going on in their emergency department currently to give you sort of an anticipated wait time. So you could be sitting at home deciding, do I want to go to emergency department A or to emergency department B, and pop onto their websites to get an idea of what your wait time might look like. And so that's sort of where we're giving the onus to the patient to decide based on that information, whether they want to come in now or later or which hospital they want to go to. But that technology is certainly not new. And I think now you're seeing more and more applications of artificial intelligence and actually like modeling where we're saying, can we do a better job of anticipating when you can be seen in the emergency department based on sort of specifics about your presenting issue? And then can we actually guide you as to when to come into the emergency department? So the initiative that Sudha was referring to is a partnership between Humber River Health and Deloitte, where we were sort of the winners of some grant funding from a federal AI supercluster called Scale AI. And what we're doing is looking at more patient-centric queuing. And so, historically we've said, if a patient presents to an emergency department with abdominal pain, for example, we can't say your wait time is going to be 4 hours. You can do that wait at home. Come in 4 hours because the risks are too high to this patient. What if we miss the aortic aneurysm? What if we miss the really bad things that can happen? I think when we look at the population, and this is what I was referring to before, is the numbers of those patients that are those really high risk patients is much smaller now because the breadth of what we do is much, much bigger and we're doing more primary care. So if we can hone in and do a better job of defining the differences between those populations, then we can support queuing applications that are more patient centric or that tell a patient when they can come in or not and help them also be empowered with the decision making of where they want to go to seek their care. I am cautious of the fact that a solution like this needs to be scaled across all emergency departments. Ultimately, what you don't want is some hospitals sort of really advancing in one space and not sharing that knowledge and information, because ultimately that goes right down to the patients and creates further inequities. And also it puts, varying different burdens on different hospital systems. And so that's not the goal. What we're trying to do is, again, in a health learning system, is try technologies like this, learn from them, and then ultimately scale them.
Thanks so much, Tesleen. And Gino, I think I'm going to give you the last question. We spoke in the guidance about the importance of accountability. Can you maybe draw on that a little bit as to where accountability sits within all of this work?
Sure, that's a great question. So we know that, and this is something that has been discussed throughout the project and especially in discussion with HTERP, but we know that accountability is such a key factor here. And so we know that we've listed some favorable interventions. We've listed some ideas for implementing. We just need to make sure that people are being held accountable for getting this out there and making these changes. So again, if you go through our guidance document, we do outline this quite clearly. And I also wanted to point out too, that there is a step 2 to our navigation guidance as well on our website. So I do see some questions here on that. If you do go to our website and you do go to the Pan-Canadian guidance, we have developed a more of an interactive type of tool where you can get a lot more information. So we're not just focused on the input, throughput, output, but you can also have a look at some of those systemic interventions that were identified in our package of work. So I do want to just highlight that as well there too.
Great. Thank you so much for that, Gino. I appreciate that. I think what I'll do now is I'm going to turn to each of the panelists and just maybe ask you to have a 1-minute closing remark, and maybe just ask for a little bit of positivity as we end our webinar. What is maybe your one hope of this work moving forward, or your one piece of sort of a positive takeaway moving forward? And I'll start with Dawn.
Thank you. I think communication, as we've talked about, is imperative. It just helps with all the unknowns in any way. And I think also my biggest takeaway is just collaboration, right? Because you don't think about who all the key stakeholders might be. And so I think when you actually reach out and collaborate with others, you recognize that the need is far reaching.
Thanks for that. Tesleen.
Thank you, Sudha. I think CADTH has done some really incredible work here, and I think this is going to have tremendous impact on the community, not just the emergency medicine community, of course, because one of the wonderful pieces of this work is how much we've been able to highlight that this is truly a systems issue and requires systems leadership. And one of the big pieces of value, I think, is the horizon scan. Even if we just focus on one of the reports, this is a place that local systems or hospitals can say, what else has been done out there and in what context? And what can I borrow from that might work in my context? Because there is going to be deviance across different systems. And so knowing what's going to work for you locally is really important. And so, I think that this will help. And when it comes to sort of my positive outlook, as you know, I think my bias is clear. I do have a lot of sort of hope for digital solutions to help attack sort of an age-old problem with sort of different thinking or a different lens. But I am positive and hopeful.
Thanks, Tesleen. Gino.
So I think we've heard many times today about the complexity of this pan-Canadian issue. And I guess I leave here today being very hopeful that our work at CADTH is starting to point us and help steer us in the right direction. But we do know it's going to take a lot, and it's going to take everyone in our health system to get us to where we need to get to. The other point that I wanted to make here is that we had an overwhelming response to the number of individuals who wanted to contribute and who were interested in our work. So I just want to take this time to thank everyone involved and let them know that we could not have done this work without your insight and your contributions. So thank you for that.
Thanks, Gino. And Maggie, last but not least, I'm going to give you a whole 2 minutes to tell
Whoa.
us. Yeah.
Thanks so much. Listen, I cannot overstate the importance of communication. We've talked about it a lot, but it's just so centrally important. I want to leave people today with the knowledge that patients are your allies. Patients want to be your ally. They want to help. They have insights and ideas. Caregivers want to be involved not just in the planning of their loved one's care, but in helping to make the system better. There are many, many caregivers and patients who really, truly want to do that. So please see us as allies and people that really want to be of help. I also want to just end on a note of gratitude. You know, as I said when I started out, I have spent far too much time in the emerge with my family and myself. And the moral injury that I have seen in healthcare workers just leaves me heartbroken. This work is really difficult. You persist and you keep doing it despite that difficulty. And I want you to know that I recognize it and am truly and deeply grateful for it. I know that the problems that we have in the system are widespread. I know that they will not be fixed with one broad sweep of anything, but I also know that what will fix them is the dedication and work that you do, and the will that we have to insist there is politically to make change. And I want to let you know that we are there for you. And despite our emotional outbursts at times, definitely have your back. So with deep gratitude, I would just like to end my comments.
Thank you, Maggie. Really, really appreciate that. I'm glad I gave you the extra minute. So I really wanted to thank all of our panelists and our audience for today's event, and really a huge, huge thank you to the CADTH team for supporting this event and helping pull this together. A very special shout out to Gino and to Laura Weeks and the entire team at CADTH for really drafting what's really an exceptional report, an exceptional body of work. And thank you to our Health Technology Expert Review Panel, or HTERP, for crafting this guidance. We're really hoping that this will be of help to all of you who are living and breathing emergency department overcrowding on a daily basis, whether as a patient or as a care provider. We're really hoping this will be of benefit. Part of our hope is really that in tackling this broad and complex issue, that we'll be able to share information on relevant interventions that could really be a starting point, not an ending point, but the start. And we really encourage you to share this work with all of your networks, continue the dialogue in the spirit of catalyzing change.